All right, we are going to move into the second part of our lecture about acid-base imbalance. So here we go. So why does the pH of the blood matter? So if you look, the normal level of pH is from 7.35 to 7.45 in that orange block. If you move anywhere to the left, so you get a lower than normal pH, you're in acidosis. And if you go too far to the left, you wind up at death. Same thing with going to the right or going to a higher than normal pH. If you go too far to the right, past a certain point, you also end up at death. So your body can't function if you don't have a normal pH level. And within a certain range of pH. And so it's really important for us to understand what normals look like, what problems can contribute to imbalances in pH levels, and how we can work to correct those problems. Okay, so the body works to maintain homeostasis, so this balance between acids and bases. Different health problems can affect how this balance is kept. So things that are common like diabetes, COPD, or renal failure can all impact the pH level of the body. Your body has different mechanisms to correct these imbalances. So the most basic thing is a buffer system. So that has to do with like intracellular and extracellular cations and those sorts of things. We're not going to spend too much time talking about that. We're going to focus more on the system of the respiratory and renal system and how they contribute to correcting these imbalances. So the respiratory system, it breathes, right? So it can increase or decrease the rate of breathing by contributing to the rate of breathing, either slowing down or speeding it up. It affects the CO2 level. As your CO2 level goes up, that makes your pH level go down. And conversely, if your pH level is high, you can breathe less often and hold on to that CO2 and correct a high pH. Hopefully I didn't just confuse you. Anyways, we're going to talk more about it. And then the renal system also has the ability to regulate. It regulates bicarb. So bicarb is your basic component, and it can either hold on to it or excrete it depending on what's happening. And if you have a problem with either your respiratory or your renal system, that would impair your body's ability to buffer. So yeah, it can get a little bit interesting if you've got these folks that have these chronic health conditions. ABGs, arterial blood gases, that's how we determine the balance between acids versus bases in the body. And these are the bits of information that you get from an ABG. So the pH level, PaCO2, so that is the amount of carbon dioxide that you have in your body. Your HCO3, we also call that bicarb, so that's the basic component. PaO2 is different than your O2 saturation. So O2 saturation is something that you're familiar with. You usually want it to be greater than 92%. Your PaO2, though, is different. And we're going to talk about that on this next slide. So normal, this is something that you're going to need to commit to memory. So make sure that you start working on these. So your pH needs to be between a range of 7.35 and 7.45. Anything less than 7.35 is considered acidotic or a low pH. And then anything greater than 7.45 is considered alkalotic or a high pH. Your HCO3 or your bicarb, the normal is between 22 and 26. Your PaCO2 is between 35 and 45, which is easy to remember because it kind of falls in line with what your pH normals are. And then your PaO2 is between 80 and 100. So your PaO2 stands for your partial pressure of oxygen, and it's how much oxygen pressure there is in your arterial blood. It tells how well the oxygen is able to move from your lungs into your blood. So you need to commit all of these numbers to memory. They're listed in your book as well, but yeah, write these down for sure. All right, alterations in acid-base balance. So you get these imbalances when your compensatory mechanisms fail. So there's different ways that we classify these imbalances. We have respiratory versus metabolic. So respiratory means you have a CO2 problem, metabolic means you have a bicarb problem, and then do you have an acidosis, a low pH, or an alkalosis, a high pH? And then is it a chronic or acute problem? So we start by looking at the pH. Do we have a high pH or low pH, acidosis or alkalosis? And then we're going to look and see if it's caused by your respiratory or metabolic system, which we'll learn how to do that next. And then we want to know if they're compensating. So compensation just means, is my pH normal or not? So in full compensation, you'll have a normal pH, but your bicarb and your CO2 numbers will be out of whack. Partial compensation means that your body is trying to compensate, but we don't quite have a normal pH yet. We're going to want to know what complications can arise from the different imbalances, how we can correct those, and what orders we should expect. Just know that acid-base imbalance is really complex. You can have a combination of these imbalances occurring simultaneously. It's really easy to get into the weeds with this, so don't get overwhelmed. We're not going to expect you to be able to determine these really complex multiple imbalances happening simultaneously. We really just want you to be responsible for the basics. So we will practice and you will get there, I promise. All right, very important tool is the Rome mnemonic. So it stands for respiratory opposite, metabolic equal. So if you have a respiratory imbalance, your pH is going to move opposite of your CO2 level. Okay, so in alkalosis, as my pH goes up, my PaCO2 moves in the opposite direction, so it goes down. Conversely, in an acidosis, my pH is going to go down and my CO2 level is going to go up. However, with a metabolic imbalance, my bicarb is always going to trend with my pH. So as my pH goes down, my bicarb goes down. And the same thing, as my pH goes up, my bicarb goes up. So just to kind of rehash that, if I have a high CO2, I'm going to have a low pH. If I have a low CO2, I'm going to have a high pH. And my bicarb and pH trend together. Make sure that you write this down. This is going to really help you be able to work through these problems. So let's do some practice. So you see our little mnemonic there on the right-hand side, and I gave you the normal lab levels there at the bottom. So let's look at A. If you see, we've got a pH of 7.26. So let's look at our normal pH. It's 7.35 to 7.45. So is my pH high, low, or normal? So that is a low pH because it's below 7.35. Now let's look at our PaCO2. Is that high, low, or normal? So my normal is 35 to 45, and that is 60. So that is much higher than you would expect. So I have a high pH. And if we go over to our Rome mnemonic, my pH is going down, my CO2 is going up. So then I have a respiratory, and because my pH is low, I have an acidosis. So that's a respiratory acidosis. So let's look at B. I've got a pH of 7.29. That is high, low, or normal. So that is a low pH. So I have an acidosis. Now let's look at the CO2. Is that high, low, or normal? That's actually normal. So then we're going to look at the bicarb. Is the bicarb high, low, or normal? So my bicarb is 20, so that's low. So if you look, my pH and my bicarb are trending together. They are going down. So that means that I have an acidosis. Okay, let's look at C. I've got a pH of 7.51. So that is high, low, or normal. So that is a high pH. So we have an alkalosis. I look at my CO2 level. My CO2 level is normal. My bicarb level, however, is 29. So that is on the high end. So my pH is high. My bicarb is high. So I have a metabolic alkalosis. Okay, looking at D, we have a pH of 7.49. So is that high, low, or normal? And that pH is high, so I have an alkalosis. And then let's look at the CO2. Is that high, low, or normal? that CO2 level is lower than we would expect. So I've got a CO2 going down and a pH going up. So I have a respiratory alkalosis. Okay, so let's do a little practice here. We're going to go through these individual types. So Jerry is a 22-year-old female who's been on a 3-day party binge. Her friends bring her to the ED after being unable to awaken her. Assessment reveals shallow respirations with a rate of 8 per minute, diminished breath sounds, and decreased level of consciousness. So what are the important points to bring out from this case study? So she's been on a party binge, okay? They can't wake her up, so she's probably pretty sedated, okay? She's not breathing well. So if I'm not breathing well with a respiratory rate of 8, what is going to happen to my CO2 level, do you think? So if my respiratory rate is lower than it should be, I cannot blow off as much CO2 as I need to, right? So that's going to make my CO2 level go up, right? So let's look here. What type of acid-base imbalance would you expect Jerry to have? So if she's got this high CO2 level, remember what happens to the pH as my CO2 level goes up? It's going to go down, right? Because my respiratory moves opposite. So we would expect her to have a respiratory acidosis. So my problem is with my respiratory system because I'm not breathing like I should be, right? And it's an acidosis because I'm holding on to that CO2. And it's caused by her hypoventilation. Compensation. So if you have respiratory depression, eventually your renal system will compensate, but it takes a while, like greater than 24 hours for your kidneys to recognize that there's a problem and start fixing it. My respiratory system can compensate pretty quickly, but my kidneys take a long time. So the chances of her having any compensation are not very high. So let's talk about her ABGs. So what would we expect for her CO2 level? So we already talked about we would expect her CO2 level to be high. We would expect her pH to be low. Her bicarb would probably be normal. If it had been greater than 24 hours, you might see an elevation of the bicarb because my body is going to want to bring or hold on to that bicarb to help bring that pH up. And then my PaO2, the partial pressure of oxygen in the system, is probably going to be less than 80. So you're going to want to treat her underlying cause. So if she's taken opioids or benzos, we want to treat for that. We can do mechanical ventilation until whatever she's taken is worn off. We need to increase that respiratory rate and depth because that's going to help blow off that CO2 level and make her pH go back up to normal. Okay, so respiratory acidosis is a problem of too much CO2. It's caused by things like hypoventilation, respiratory failure, and again, eventually your kidneys will compensate by retaining CO2, bicarb, and they can also excrete hydrogen. About respiratory failure, it could be something like acute respiratory failure or ARDS, acute respiratory distress syndrome, where you have this leakage of fluid into your alveoli, or SARS, which is severe acute respiratory syndrome. It could be lung related, but also sepsis and shock can cause respiratory acidosis. All right, let's move on to case study number 2. We have our friend Maina. She's an 18-year-old female who presents to the ED with a panic attack. She's hysterical and in severe emotional distress. Her blood pressure is 140/96, heart rate 104, respiratory rate 38, oxygen sat is 96. Lung sounds are clear. So let's look at this. What's important in her case? What's happening to her respiratory rate? So it's opposite of what we were dealing with before, right? It's too high. So if I'm breathing really fast, what's going to happen to my CO2 level? because I'm exhaling a bunch more than I was before, right? So it would be a respiratory cause, right? Because we have that respiratory rate of 38. But if I'm getting rid of my CO2, I'm getting rid of my acid component. I would expect my pH to do what? To go the opposite, right? So my pH is going to go up. So I'm going to have a respiratory alkalosis because of the hyperventilation. Would I expect compensation? No. This is an acute problem, a panic attack type event. People with really bad pain can also experience the same sort of thing. There wouldn't be time for the 24 hours needed for my kidneys to start compensating. ABGs. So her pH is going to be high. Her bicarb is going to be normal. Her CO2 is going to be low. How do we treat it? We'll treat her anxiety. We're going to help her with some slow, deep breathing. We can even have her breathe into a paper bag because that will help her rebreathe some of the CO2 that she's been blowing off. So respiratory alkalosis is just a problem of not enough CO2. It's caused by hypoxemia from pulmonary disorders and hyperventilation. Compensation, again, is rare because these events are acute. If it is a chronic event, chronic problem, then you can have some renal compensation. Okay, so let's go to case study number 3. We've got our friend Alan. He's a 17-year-old male who comes into the clinic saying he feels bad with fatigue, constant thirst, and frequent urination. Focused assessment reveals deep, rapid respirations at 28, fruity breath odor, and he's got a blood sugar of 484. That's not normal, right? What type of acid-base imbalance would you expect Alan to have? So he doesn't have a breathing problem, right? He has a blood sugar problem, which is also known as a metabolic problem, okay? So he's going to have a metabolic acidosis because he's breaking down fats for energy because he's got this DKA happening, okay? Secondary to the lack of insulin, and then his body can't utilize glucose. He's creating ketones, and the ketones are going to make that pH go down. They're an acid byproduct when you start metabolizing fats, okay? The deep rapid respiratory rate, the Kussmaul respirations, are respiratory system compensating. You can get full or partial compensation depending on how long you've had this hyperglycemia. So remember that your respiratory system can compensate much faster. So Alan's ABGs. We would expect him to have a low pH, right? His bicarb is also going to be low because those are going to trend together. My PaCO2 could be normal or low if I'm starting to compensate, and my PaO2 should be normal. What's the treatment? He needs insulin, fluid, and electrolytes to help replace these losses. So 2 main causes of metabolic acidosis. We either have an accumulation of too much acid, things like DKA, lactic acid accumulation, so things like shock, or we have not enough bicarb. So we have really severe diarrhea where we're just having lots of output, or kidney disease. And compensation is going to be your Kussmaul's respirations, or your kidneys can actually secrete excess acid. And ketoacidosis, this accumulation of DKA, the lactic acid with shock are examples of this acid accumulation. Diarrhea results in a loss of bicarb. In renal disease, the kidneys lose their ability to reabsorb bicarb and they secrete hydrogen ions. All right, last one. We've got Anthony, a 54-year-old male with a history of nausea and vomiting for the past week. He's been self-medicating himself with baking soda to control his abdominal discomfort. So what's baking soda? An acid or a base? It's a base. Okay, so he has basically been loading himself up on base by taking baking soda. I don't think you see this too often anymore, but you probably could run into it. So what do you think is going to be up with his pH? So probably pretty basic, right? So he's going to have a metabolic. It's caused by the GA system. It doesn't have anything to do with his respiratory system, and it's going to be an alkalosis. What's causing it? It could be the loss of gastric acid because he's been sick at his stomach, and then this addition of excess bicarb. So the deal with compensation for metabolic alkalosis is you can only slow your respiratory rate down so much. Your brain is going to start kicking in and make you breathe quicker, okay? Your kidneys can excrete bicarb. Your respiratory rate can go down, but when your CO2 level gets too high, then the chemoreceptors in your brain get stimulated, and that causes your respiratory rate to go back up again. So limited compensation for metabolic alkalosis. Again, his pH is going to be high. The bicarb is going to trend with it and also be high. The CO2 could be normal, or it could be high because you would raise that CO2 level in an effort to bring that pH down. What's the treatment? We want to treat that vomiting. We want to tell him to stop taking the baking soda because it's not helping, and then replace any lost fluids and electrolytes. Okay, so metabolic alkalosis, you have too much bicarb. So you have prolonged vomiting or gastric suction, or you've added too much bicarb. And then that compensation again can be renal. You can excrete excess bicarb, or respiratory. You would decrease the respiratory rate, but that is only so far. Alrighty. So we're going to pick up with this one when we meet for class on Thursday. I hope that this has been helpful to you guys, and please bring any questions that you have to class, and we will try to sort through them. All right, thank you.